Hi, everyone, and welcome to today's course about the Norwegian healthcare system. So my name is Fredrik Hoff Nordum. I'm an anesthesiologist working in the Oslo area with previous experience as a paramedic, and I've also been working in pediatrics as a doctor and a little bit in cardiology. And I've also did my internship or the LIS1, the turnustjeneste, up in the very north of Norway in Finnmark. So I've also experience with like working in rural systems as well. So I'll be guiding you through today's course. So this is quite a comprehensive list of what we'll go through today, but we'll dig deeply into some of the topics, and the other topics is perhaps more suitable to look through the compendium. So we'll briefly touch on all of them. We'll start with the organization of the Norwegian healthcare system. We'll look at key services like general practitioners, nursing home, and emergency medical communication centers, the AMKs, AMK, and the out-of-order clinics. We'll look at the different healthcare professionals in Norway. We'll look at how to find a job and where to apply. We'll look at how to get licensed or authorized as a healthcare worker in Norway. We'll look at some work permit requirements and how to apply for a work permit for those who need it. We'll also go through if you need it. Kind of depends on your country of residence currently. We'll talk about some Norwegian learning language tips for international healthcare professionals. We'll also look at some communication strategies while you're still learning Norwegian. We'll specifically look at antibiotic use in Norway because we have quite different guidelines for antibiotic use in Norway compared to even compared to the other Scandinavian countries, and especially compared to like Central, Southern, Eastern Europe, or yeah, basically the rest of Europe. So I'll get back to that, but that's an important thing to look at, especially for the medical doctors, but also for nurses and paramedics and other kind of healthcare professionals. So we'll look at some national procedures, like our resuscitation protocols, which are also different from the rest of the world, basically. We also have some national procedures for palliative care, some cancer pathways. I'm obviously not going to go through all of them, but I'm gonna show you where we can find them. And those kinds of stuff will obviously be better suited for the compendium. Like the most important thing is just like having a list of links that you can access. So if you're like working as a general practitioner or you're working as a nurse in a nursing home, just having all of those resources, like adding them as a bookmark on your phone so you know where you can find them. Just knowing that there are different regimens for antibiotic use in Norway, and just saving it, the guideline relevant for you. We have one for the specialist health service and one for the primary healthcare services, and just saving the relevant for you like on a bookmark on your phone could make your life so much easier. So just knowing that there is a difference and where to find the guidelines, then you can always look them up when you need them, and usually you have the time to do that. I like to say when I'm teaching emergency medicine that the only thing you need to know the doses of are like adrenaline or epinephrine and like cardiac arrest if you're doing ACLS, or to be used in anaphylaxis. All other kinds of emergencies, then you have time to look up the doses. Usually there are some exceptions, like we as anesthesiologists can't really look up the doses when we're performing emergency anesthesia to a C-section, for example, but generally speaking, you have time to look up most stuff. And we're also holding a course in Norwegian about the treatment of sepsis, and even in the mostly severe patients with septic shock, you still have time to look up like the correct doses and regimens for antibiotics. Okay, so we'll also look at some legal essentials in Norway. I'm not like going to cite specific laws, but I'm gonna give you an overview of some laws that you should look into and like provide a brief overview of the general concepts of those laws. Okay, and yeah, we'll also look into some digital resources for healthcare professionals and some unique challenges in rural areas and smaller hospitals. And generally speaking, a lot of you will be working in rural Norway and in smaller hospital. That's where you are basically most needed and where it is frequently both easier to get a job and it's also frequently higher paid. So especially if you're working with like an agency that hires you, then they are usually deploying you to the more rural kind of areas. But that's great experience. You'll get to develop yourself both as a medical professional and also discover some unique nature and some really fascinating people and communities. Okay, so we'll start about talking about the general organization of the Norwegian healthcare system. So one principle that we have in Norway that is, I wouldn't say it's unique for Norway, but compared to some other countries, at least, we have like universal healthcare for all. So you don't need to have like an insurance or anything like that. Everything is, I wouldn't say everything is paid for. You are to pay like a small fee when you're visiting your general practitioner and when you're having like a scheduled appointment at the hospital and so on. But those small payments, they are kind of capped at a maximum. So you can't really spend that much on healthcare in Norway. And also for essential medication, they go into like the same cap. So once you like spent a few thousand kroners on healthcare in a year, you get the free court, like the free pass, and then you basically get, you don't get all the healthcare services you want for free, but you get what you need. And there are obviously insurances and stuff in Norway as well, but actually for most issues, like the public hospital actually has the greater competencies. You can go with your private insurance and operate like on your aorta or do like major invasive surgery or get treated after trauma. So some elective procedures, yes, you can use your insurance and you can perhaps bump up the line and get treated faster. But generally speaking, we're heavily relying on our public health service, which means that you're guaranteed those services, even if you're without a job and having economic struggles. So yeah. So obviously we have some unique challenges in Norway. I don't know if it's really true. I haven't really measured, but they say that if you're measuring like the distance between the south and the north of Norway, then and if you were to go the same different distance just the other way, then you'll be down at the bottom of Italy. So obviously there is a long way here, and compared to going down to the south of Italy, our roads are far inferior. And due to the weather conditions, especially in like, or I wouldn't say like especially the north and west of Norway, but we have some bad roads here in the east side as well, and more I, I don't know if I can say central regions without people getting hurt, but yeah, we have some bad road conditions in a lot of our country, and they are susceptible to weather conditions. And when I was working in a small rural community called Havøysund up in the very north of Norway and doing my turnustjeneste, my LIS 1, or like my general internship after graduating as a doctor, then my closest hospital was like 2-3 hours away with ambulance, which actually wasn't that bad compared to many other places. The only issue was that was if the road was open, and sometimes the roads were closed, and they could like try to plow the road open, but sometimes even the trucks with the big snow plows weren't able to do that, even like if they had some kind of they had a procedure for like emergent plowing in front of the ambulance, but if the weather and snow were too bad, then they couldn't do it. So the patient, I remember one time had a really septic patient, gave fluids and antibiotics and sent him off to the hospital, and then like 1.5 hours later, I was called by the ambulance and they had to return basically. So then we had to treat him like in the community, and there's no hospital there. There's like a nursing home and like an emergency bed that we could kind of use. So yeah, you get to face some unique challenges. Obviously, we have the helicopters, but they are perhaps even more susceptible to weather, especially fog. So yeah. Our healthcare service is divided into the primary and specialist healthcare service. So the primary healthcare service is most of the cases, at least for minor issues and also larger issues as well, but kind of the more non-emergent stuff. That's like the primary contact point, the point of contact for the patient. And for more emergent cases, it could also be like the primary part of our healthcare service, but it could also be directly from the specialist service, basically because the ambulance service is organized through the specialist or hospital healthcare service. So the primary healthcare service is like the general practitioners and also the legevakt, which I'm going to talk about a bit, which is a quite unique Norwegian concept. These municipal emergency rooms that are usually not tied to the hospital, and it's usually or are funded by like the local communities. So because we have these vast these vast distances, we can't really have hospitals all around the country where people live. So to provide some emergency service for those people, we have these municipal emergency rooms or legevakt. And most cases can actually be treated there. They can often have done x-rays, they can have antibiotics started, and the doctors working there, they can also do home visits and visit nursing homes and so on. And the idea is that the primary healthcare services are supposed to treat as much as they can, and when people are in need of more specialist healthcare services, they are referred either planned or emergently to the specialist healthcare services, which are usually located in hospitals and also specialist clinics. So obviously there are more to this, but that's the basic division, and it's also there are also differences in funding. The specialist healthcare services are organized in these regional healthcare trusts, and the primary services are funded through both their local government and also some governmental services. So this is an overview of the akuttsykehus, or the emergency hospitals that we have in Norway. And you can obviously see that there are some regions of the country where you need to travel quite far to get the help you need. And if we're looking up here in the very north in Finnmark, I think it was over here, so I wasn't that far from Hammerfest. But if you're here out in the Finnmarksvidda, then you have obviously a longer duration to travel. And the hospital in Hammerfest and Kirkenes, they can take a lot of emergency patients. They can do like infections, sepsis, they can do some obstetrics, they can do labor and delivery and so on. But if you need like cardiac surgery, you need brain surgery, you may be been to a major trauma, then those hospitals can't like fully treat you for your condition. So then you'll need to be referred to the university hospital in Tromsø, which is like, yeah, it could be like a day to travel if you travel by road. So there's obviously some challenges here. And one of the issues for me working up here as a doctor was the psychiatry patients, because obviously there are some services available for psychiatry up here locally, but for like emergency psychiatry and for patients who are admitted to psychiatry services without their consent because they were so unwell, they were maybe in danger of hurting themselves or others, so they needed to be escorted, often with police, to the hospital. Then they don't offer those kind of emergency psychiatry services in these local emergency hospitals. So basically, the psychiatry patients needs to be escorted with plane to Tromsø, which is a real logistical challenge, especially since the airport is not in like the local communities, and there are police officers involved, and the police officers they're not easy to find either up here. So yeah, you can get to experience some quite unique challenges. And we're getting fewer and fewer hospitals in Norway, and sometimes just to like keep the local hospitals, people are really care a lot about their local hospitals, and there are huge protests when some of the hospitals are canceled. So to kind of avoid that, sometimes we have like several hospitals in quite a small area, but then they have like a division of services, which means that one of the hospitals serves like orthopedic problems, where one has the labor and delivery, one has neurology, the one has pediatrics, and so on. So compared to where you're currently working, then this division may cause some trouble for you. So it's important that you get to know like which hospital in your area of work do deal with different kinds of problems. And if the local hospital doesn't deal with a particular problem, then where do you send the patient to? So make sure to make yourselves familiar with that. So the one of the important parts of the healthcare service and the primary healthcare service is our general practitioners. So everyone in Norway are supposed to get assigned a general practitioner. Someone doesn't get it. They're put on like a waiting list because we have a shortage. But the principle is that everyone has a general practitioner that is funded by the government, and you pay like a small fee up to this cap that I'm talking about for a few thousand kroners. So usually the general practitioner is the first point of contact for the patient, and one of the most important role of the general practitioner is to obviously diagnose and treat the patient as he or she is competent enough, and only refer the people who need it to the specialist service, kind of being a guard of those limited resources. So that is both true in the more elective kind of cases, but also in emergency cases. And the general practitioner is actually also the primary contact point for more emergent cases. So obviously, if you're having like a heart attack or cardiac arrest or been drowning, then you call the ambulance service 113. But If you have cut that needs stitching, or you have pneumonia and you need to be seen by a doctor today, if your GP is open, then you don't go to the legevakt primarily. You call your local GP and you get like an emergency appointment there. And there are several reasons for that. Usually the legevakt or the local emergency clinics, they are not staffed, or not staffed as well, at least in the daytime when the GP's offices are open. And having a doctor which knows their patients is also a major asset when treating like emergent cases. So that's like the primary contact point. And that's also important if you're working as, say, a nurse in home care nursing. And then if they're, depending on your like local protocols, usually the one doctor you should get in contact to if there's an issue with the patient, even if that issue is like emergent, but maybe not life-threatening, is the general practitioner and not the legevakt. So what is the legevakt? The municipal emergency rooms, I touched briefly on it, and they are like a replacement for the general practitioner out of office. So either if it's the middle of the night or the evening or the weekend, or maybe the general practitioner is simply not able to help the patient because all the emergency appointments are taken up and the general practitioner is doing a home visit to another emergency, then the legevakt kind of fills that need. And usually the legevakt is like a small emergency room that is placed somewhere in the community, but it's organized in different ways. And me working up in the far north of Norway, there in the small community of Havøysund with around 1,000 inhabitants, then the legevakt was basically a phone and an emergency radio that I took with me home. And when the patients wanted to get into contact, they called like a central dispatch central that kind of filtered the calls to determine if this was something that needed to be dealt with, like in the middle of the night. And if they deemed that I should know about it, then like the call was set over to me. And then if I needed to see the patient, then I could either go to their home or I could meet them basically at my GP's office, which was also serving as the legevakt. While in major cities, it's a huge institution, so it kind of varies. But it's always organized by the local communities and not by the hospitals. Sometimes they are co-located, but they are two kind of completely different institutions. And usually the doctors staffing the legevakt is also general practitioners, which are there either voluntarily or they are forced to do it as some kind of duty as part of their contract. Kind of depends on the arrangement where they work. And some other people like myself enjoy working legevakt. So even if I'm working in anesthesia in my day job, then I do some legevakt on the side because I like to keep like my broad general knowledge. I'm usually working at a car that is associated with the legevakt and just seeing patients pre-hospitally, both with blue lights and sirens, and also more visits at the nursing home and elderly people with falls and frailty and delirium and so on. So yeah, that's the legevakt. And so we have touched about that. And the legevakt also have like a central where people call in. Usually the patients are not supposed to just meet up at the legevakt. They are supposed to call the number 116 117, and they're usually put over to a nurse that could assess the situation. They could tell the patient to go see their general practitioner if it is in within the GP's office hours. And they can also kind of triage the patients. And if it's a case that doesn't need to be seen physically by a doctor or a nurse right now, they could just give advice over the phone. And they have the ability to turn on cameras and phones so they can have a look at cuts if it needs stitches and so on. So, and it could also be an asset for if you're working like in home care nursing, then you could call the legevakt, the nurse there, and discuss with a colleague, and you could also be transferred over to the doctor on call and discuss the issue at hand. So the Legevakt Central are working closely together with the AMK, the Emergency Medical Dispatch Central, where the number is 113, which primarily dispatches ambulances, cars, boats, and helicopters. But obviously, these two are working closely together. So there is a divide, and 113 is for the more life-threatening stuff, like cardiac arrests, severe breathing problems, severe bleeding, kind of the really time-sensitive stuff. And the legevakt is for the more urgent but not immediately life-threatening stuff. But obviously, people call the wrong place, and these two centrals work closely together. And they also kind of help each other out when dispatching the resources. So even if the call comes into the 113 central, the doctor from the legevakt could be dispatched alongside the ambulance as well, which is much more common in the rural areas. And sometimes the ambulance isn't even available, and the doctor from the legevakt or even the nurse is dispatched on their own. So, and depending on the assessment by the personnel on the ambulance or the doctor at the legevakt or the nurse, then the patient could either be sent to a legevakt for more observation and treatment. And in some communities, they have like a local medical center, which is usually a collaboration with the specialist and primary healthcare services, meaning that there are co-location of these services, meaning that they have some more advanced capabilities. Maybe they have access to CT scans, at least in the office hours. They usually have X-rays, and they have small local wards that can treat patients with issues that are too severe to be sent home, but maybe not needing to go to the big hospitals. Maybe they just need someone to give them some pain medication after fall, or help with mobilization, or they need some IV antibiotics for a pneumonia, but they don't need like advanced respiratory support. And all of these services are differently organized in different communities. So one of the things that you need to do your research on is, when you're working in a local community, how these things are organized there, because there are vast differences in my experience. So the Emergency Medical Communication Center, so the AMK, the people you reach when you call 113, it's staffed by nurses, EMTs, and paramedics who respond to the calls. So if you identify yourself as a healthcare professional and tell your professional title, then you'll also get some advice tailored to that. So they are not just dispatching the ambulances. What's usually the case is that you have the operator who takes the calls, and both do a triage if an ambulance or some other kind of resource is needed or not. And if it's needed, then how urgent is it? Does the ambulance need to go with blue lights and sirens, or can it drive normally in the traffic? Or can we perhaps arrange just like a taxi to the legevakt or something like that? And at the same time, the dispatcher is listening in on the call. And if it's obvious that an ambulance is needed right away, then the dispatcher can immediately dispatch the ambulance while the operator is giving advice. So that's that way the ambulance is dispatched quickly when needed. So the thing is that you get really good help also as a medical professional when you call 113. They are skilled and trained to guide you through some emergency procedures when you call them, if it's like a life-threatening emergency. So the Norwegian EMS system is comprised mainly of road ambulances. There are always two healthcare professionals on board, as well as a lot of equipment. And they are authorized usually as ambulansearbeider, EMT, or paramedicine. And other kind of authorized healthcare professionals, like nurses, can be part as one of the crew members if they have additional training. So, but in most cases, you'll meet an EMT or a paramedic, or in some cases, a nurse or a paramedic student with some additional training. So they are used to working quite autonomously. They have delegation to usually give a lot of drugs without consulting with a doctor, and have advanced both advanced monitoring and airway capabilities in most cases. They rarely do endotracheal intubation on their own, but they have supraglottic airways like eye gels and those kinds of stuff. And we also have the air ambulance service, which is staffed by an anesthesiologist with advanced airway capabilities, as well as a rescue officer, which is usually a paramedic, EMT, or nurse with additional training, especially in advanced rescue, as well as the pilot. So they are unfortunately a few and far between, but they offer superior speed to reach both the patient and their final destination of the hospital, and also the most advanced treatment available pre-hospitally. And in some major cities, they also have teams with doctors with similar capabilities in rapid response cars. And we also have some boats as well, which are usually both staffed and equipped like the cars, but more often than not, they have some additional capabilities and equipment. So we also have some options for the patient who doesn't need advanced monitoring, but are just like limited in their mobility, so to say. So there we have like these syketransport, or these medical transport vehicles, the white ambulances, which are staffed by two people who have advanced first aid training. They have some training in observation, and many of them are under education to become like an EMT or a paramedic, or they have been that before, but they are kind of winding down before retiring. So they are usually staffed by people who can indeed provide some observation of the patient, but generally speaking, these services are reserved for patients not needing monitoring, and there are also limits to the monitoring equipment in these vehicles. So when you talk with the emergency dispatch central, there are both the 113, the emergency number, but you will also probably be provided, if you're working in collaboration with them, and some other numbers that are supposed to be used for more non-emergent circumstances, like arranging a transport home from the hospital and so on. And then it's important to be clear on what the monitoring needs of the patients are, because obviously we don't want to use an ambulance staffed with highly trained people with a lot of expensive equipment if the patient could just go in a wheelchair taxi, for example. Here you see a map of the air ambulance bases. So we are usually covered by one of them in most parts of the country. Unfortunately, not all, and not really sure what the red and black lines symbolize. But the thing is that even if you're within the area served by the air ambulance, they have limited flying times. So there are strict regulation in the aviation industry, meaning that the pilot and basically the entire crew, if they've flown too many missions, then the helicopter is basically grounded, and another crew is not automatically sent in, at least not for a while. So the air ambulance can be unavailable, and there are obviously also weather conditions and emergency incidents happening at the same time. So you are not always able to get an air ambulance, even if that would be the best for the patient. We also have the rescue helicopters, which are staffed medically in the same way with an anesthesiologist with the same capabilities and also this rescue officer. But they have additional crews as well, and the helicopters are better equipped for tougher weather. They can hoist patients up in the rescue helicopters, not just having someone hanging from a line below. So they can hoist people in, which the regular air ambulances can't. And they have some more advanced equipment for search and rescue, especially. So, but they also serve some of the same purposes in terms of also working as an air ambulance, but they have enhanced rescue and search capabilities. So, some of the key takeaways so far about the Norwegian healthcare system is that everyone in Norway has the public healthcare coverage. The system is paid by taxes with only small co-pays. So the co-pay is the small amount that you pay when you're at the doctor's office. And the co-pay, it reaches a maximum, as I told you, and it can also be voided in some instances. So it's the same system with co-pays also at the legevakt, but for example, I opt to remove the copay when I have like patients with severe mental illness, because if I go to their home and I decide that they are too unwell to be at home and they actually need to be taken to the psychiatric hospital against their will, I don't think it's fair that they get an invoice afterwards with asking the patient for money. So, and there are exceptions to the copay. All things related to pregnancy, children, and other conditions means that the copay is completely voided. So, as I alluded to, the GPs are the first stop and control the access to the hospitals. You can't really call the hospital as a patient yourself and ask to be seen unless you're like a regular patient there being treated for, like, say, advanced cancer. Then you will have a person in the hospital that you can call, and you don't need to go through the primary healthcare service if your issue is related to the cancer illness. And also the same applies when a patient is newly like operated in the central hospital. But usually it goes to the general practitioners, either at their offices or when they are working at the legevakt. And the ambulance crews, the EMTs and paramedics, depending on the region where they work, and how unwell the patient is, they can also admit the patient directly to the hospitals. But if the patient is not so unwell, then they maybe need to consult with a doctor or transport the patient to the legevakt to get the patient assessed. So the municipalities handle primary care, and the regional health authorities, they run the hospitals. And HealthFu is the organization that take care of payments and the copay tracking. So when you reach the limit, then the patient doesn't have to copay anymore. And if they have paid over that limit, then they get it refunded. So the two important numbers are the 113 for the life-threatening stuff, and the 117 for the urgent but not life-threatening. But even if it's urgent and not life-threatening, and it is within the opening hours of the GP's office, that's the primary contact point. And some people are complaining about the telephone lines at the GP's office, but that could also be true for the 116, 117. So obviously, if it's so urgent that you don't want to wait half an hour, then you can try calling into the legevakt. But generally speaking, the GPs are the primary point of contact. So now we're going to talk about different healthcare professionals and their roles in Norway. So in Norway, we officially regulate 33 healthcare professions. And if you want to work in one of these, you must be licensed and registered within the Health Personnel Register, or the HPR, the Helsepersonellregisteret. And if you're not registered there, say as a nurse, then you're not allowed to call yourself a nurse in Norway, and you're not able to work and take on the responsibilities of a nurse. So if you want to work in Norway, you have to get registered, even if you're registered in another, say, European country. You need to get registered here. And the registration process is fairly straightforward if you're in another European country, or at least in the EU. Okay, so I'm not going to go through all of those healthcare professionals, but in our course compendium, there will be like an overview of all of them, because there are differences between the different countries, where in regards to what the types of healthcare professionals available, and also the responsibilities may be different than what you're used to. So when you're starting working and you see, okay, I'm working with some helsefagarbeiders, and I'm working with some fotterapeuts and so on, you can go and look through the list and basically get an overview of, generally speaking, what are the educations and competencies of those different types of healthcare professionals. But the most basic usual stuff is probably the same as you're used to, like doctors and nurses and so on. So we also have specializations. So some of the specializations are regulated there, but in some cases they are regulated separately from the Helsepersonellregisteret, which makes the the application process even more cumbersome. So for doctors, for example, they are administered and approved by the professional organization, i.e. the Norwegian Medical Association, or the Norske Legeforening. So if you're like a specialist in orthopedic surgery, then you both need to apply to get the license as a doctor in Norway, and then you need to talk to the Norwegian Medical Association to get your specialization approved. So just be mindful that those can be two different things. And I would advise you to find the national organization for your professional group and talk to them and get some advice, especially if you have a specialization, how you can get that converted to the Norwegian equivalent. So you can actually work as an anesthesia nurse, for example, because that are regulated quite heavily. Okay, so how to get the license or get authorized as a healthcare worker in Norway? If you are a healthcare professional trained outside of Norway, this was actually the case for myself because I studied in Denmark. Then I needed to go through this process. You need to go through the same process even if you're trained in Norway, but it's far easier then. So you must get this license before you can practice, and the process depends on where you were educated. So it's not a process that is depends on where you're currently living. It's the place that you were educated that counts. So if you're educated in the EU or the EEA, that is the European Economic Area, or in Switzerland, there is a simplified pathway. If you are, educated outside of that area, there are more steps and a lot more time required to get the license, unfortunately. And the reason being that the education system and standard within the EU is has a lot of similarities, and they basically follow many of the same standards, which means that for most healthcare professional, say for doctors, for example, then the universities in the EU which offer medical studies, they are like automatically approved. Whereas if you're having your degree from a university on the other side of the world, then the Helsedirektoratet and the people working at the Helsepersonellregisteret, they need to like look into your particular university and assess if the quality and education is on par with what we expect in Norway. It usually is, but they need to like confirm that, and also confirm that the documentation is legit and not falsified, for example, which is more cumbersome when it comes from a university that Norway doesn't know that much about. So if you're from an EU or EEA, or if you're from Switzerland, I'm sorry, if you're from there, but if you have studied there, that is taken your degree, you apply through Altinn, which is basically the portal for online for everything that has to do with the government in Norway. So when I'm delivering my taxes, I go to Altinn. When I'm having a kid and need to go on paternity leave, then I register that in Altinn, and a lot of other stuff as well. So it's like the portal for everything that has to do with governmental services in Norway. So that's also where you apply. So the first step is to just gather all of your documents, and you may need some additional stuff. So you maybe need to go to your university and get that, depending on the language and so on. You will need a diploma, and depending on the language of that diploma, you will also maybe need a transcript, a translation of that diploma, and a certificate of conformity. That is basically a national body approving the copies that you have made. And sometimes they also need to approve like the translation and so on. So you can't really just put your diploma in the copier and make copies and send them, or in the scanner. You need someone to actually approve that the copy is legit. But look into that, because it can be a little bit different depending on the language of the diploma itself. So if you're already certified in another country, then you want to also get a certificate for that. So if you're certified as a nurse in Spain or in Denmark, then you also want to have a confirmation of that, which can make things easier. And you also need a passport or national ID. Obviously, not a Norwegian passport, but from the country that you reside in or that you got your passport from. And you submit your application through Altinn, and you'll get all the steps you need there. And you can either log in with our unique Norwegian identification system, which you may be not familiar with, but you could create a guest account. But when you're starting working in Norway, you will need this national identification system, which is basically a two-factor authentication mobile app for the official Norwegian services. And you pay a fee of about 1,600 kroners, or yeah, it was at least before the kroners went way down south. It's about, yeah, I would say 150 euros, or it's not the same as $150, but it is in that range. I'm not sure about the course just now. So it could take up to 3 months, which you need to plan for and prepare for. Sometimes it's much quicker, but you can't really depend on that. So it could be a substantial waiting period. If you get when you get the result, then you can get the full license, or you could get like a temporary license with some additional requirements to get the full one. Like for doctors, you may be due to do like the LIS1 internship in Norway. That is the part of 1.5 years after the medical studies, when you're working 1 year in a hospital, seeing different kinds of patients and working both a little bit in medicine, a little bit of surgery as like the most junior doctor there. And then you're working in the primary healthcare service in half a year as a general practitioner and doing a lot of legevakt. And it could feel a little bit backwards, but some people are actually required to do that even if they have a specialization or are close to it. So my friend from Sweden, who was like a few weeks until he was a specialist in anesthesiology, he had been working as a doctor for several years. He needed to do at least part of this LIS1 stuff to get to work as an anesthesiologist in Norway. So he went from like being an experienced anesthesiologist to basically needing to work as the most junior doctor in the hospital. So it could be a bit backwards, but that's the way it is, unfortunately, at the moment. So you don't need to show any Norwegian language test results to get the license, but you will need to demonstrate your language skills to get a job, and it kind of depends on your language. If it's Scandinavian, they usually doesn't require anything else. It's usually fine. Obviously, you should do some effort to make yourself better understood and to better understand. But if it's something else, then the employer may have additional requirements for you, like basically asking you to take a test. Okay. So if you're outside of the EU or EEA, then it's much more cumbersome and it takes much more time. So the process has two main steps. You still apply through Altinn. So the first step is the evaluation of the education itself. And the second step is to complete some additional requirements. So the first part is basically sending in all the documentation and all the other stuff they need, like the translations, the proof of conformity, and so on. Make sure that you look through their checklist and have everything there. And then they will do a complete audit of your education institution, which takes a while. When that is approved, then you will need to complete some additional requirements. That may be a language test. It may be for some healthcare professionals. Then you maybe need to do some tests in that field, like do a test of medical procedures and different procedures in Norway. Yeah, so it could be like language, practical tests, etc. So the whole process, actually just the first step of the process, it usually takes more than a year. So you need a lot of time for this. The step 2 can, in some cases, be completed after you start working. So there is like an agreement that you need to provide so-and-so within a year or something like that. But generally, this is a time-consuming and cumbersome process, unfortunately. So that's to be licensed as a healthcare professional. I'll briefly talk about how to get a work permit, and then we'll take a short break and continue with actually working as a healthcare professional in Norway. So one thing that is important is that you understand the difference between licensing, that is getting authorized to practice as a healthcare professional, and immigration and residence permits, which are two completely different things. So the one thing is this is about you as a paramedic, for example, getting a license to work as that in Norway and to do your professional obligations. And the other thing where you apply to a completely different regulatory body is to basically get a permit to live in Norway and also to work in Norway. And that you do through the UDI. So if you're from the EU or EEA, it's simple. It's the principle of like this free flow of goods and services and also of the workforce within Europe. So you don't need a work permit, fortunately, to live or work in Norway. However, you must register with the police if you're staying more than 3 months. So remember that, and that is basically if there were to happen like a natural disaster or something like that, the police basically needs to know who lives in Norway for a prolonged kind of time. More than 3 months, then you're usually not a tourist, and you're like more permanently residing here, and you need to just register that. There is no like application that you need to get approved. You just need to fill out a form and tell them that you're here. So you must still get the professional license before practicing, though, as we talked about. If you're outside the EU, unfortunately, it's again more complicated and time consuming. Then you need a permit to reside and work in Norway. So there are two main options, but generally speaking, only one of them is what you're looking for, and that is option 1, the skilled worker permit. That is what's most common for healthcare professionals. And to get that, you must have a job offer in Norway. So the way it goes is that you need to first get the medical license for your profession, and then you apply for a job. And if you get an offer for a job that is equivalent to 80% of a full work week or more, so you could get a job that is just like working 4 out of the 5 hours, 4 of the 5 days of the work week. And then it's okay, but you can't do like 50% of the working time, then you will not get it approved, at least to begin with. So they also look into if the job matches your education. It's not so much an issue for healthcare professionals since it's so highly regulated to get the license in the first place. So if you have got a job as a nurse, then you will probably have both the correct license and education. But for other lines of work than healthcare, they frequently refuse people to get the worker permit. Say if there are they get a job as like a plumber and they have no formal plumbing education, for example. Then we don't want those plumbers basically pretending to be plumbers in Norway. Yeah, this I've talked about, and the application is through UDI, the Norwegian Directorate of Immigration. And here there is also a waiting time, not so long as the license though. And you can also get a job seeker visa to basically reside in the Norway while you're applying for a job to temporarily, and then you move on to option 1 when you get the job. So there will be more details and the links you need in the compendium. Okay, so I hope you have had a good break, and we'll continue briefly about the language requirements. I have touched on some of those points earlier in the presentation, but just to summarize, you do not need a Norwegian language test to get your immigration permit. And if you're from an EU or EEA country, you don't need an immigration permit at all. However, det Helsedirektoratet, they require Norwegian equivalent to B2 for professional licenses for healthcare professionals from outside the EU. So I talked about if you're applying from outside the EU to the Norwegian Directorate of Health to get your license, then there is like the step 1, the evaluation of your education, and there is step 2, which is the additional requirements. So this goes into the additional requirements, and almost universally they will require you to have to prove that you're proficient in Norwegian corresponding to a level of B2. And there are different tests that you can do to prove that. And you can also have some university degrees in Norwegian with a certain mark and so on. So look into that. But even if it's not really required to get the license for people applying from the EU, it's most certainly a good idea to both for yourself and especially when applying for a job to take a test in Norwegian and kind of document your language skills. So say you're a paramedic from Germany applying, then you won't need it to get your license, but it will in some cases even be a demand from your employer when you're hired. So always have that as like the minimum mark for your language skills. Unless you're from another Scandinavian country, then usually it's not so strict. And usually in the job listings, they say that it's sufficient to be fluent in either Norwegian, Danish, or Swedish. But as we know, there are some differences in the languages in the Nordics, and you may speak your native language, but you are required to make some changes. For example, we have a different kind of number system in Denmark and Norway. So when I was working as a doctor in Denmark, I needed to change that. I basically tried to speak as Danish as I could, but that's up to the individual if they want to do that. So anyway, so you cannot really get a job based residence without your professional license, and you can't get that without Norwegian. So that is always something that you need to keep in mind to get your language skills and get them documented. So, common reasons for rejection of the work permit, like generally speaking, is no valid Norwegian license yet. You need that in place. You need a job or salary, or I'm sorry, if you have a job or salary below the required income level, which if you're dealing with a professional employer or you're employed within like um, the governmental care system in Norway, you will get a salary that is far above the minimum required. So if you ever have like your work permit and not approved because of this, then you're basically, when we're talking about healthcare, dealing with an unserious private employer that are trying to exploit you because you will get a salary that is well within the requirements to get the work permit. So it's usually not an issue for healthcare workers, but it could be an issue for like construction workers and so on, where the payments are not that regulated and where there are loads of different private institutions and companies working. So if the documentation is incomplete or not formatted correctly, if the education doesn't match the job offered, we touched upon that, or if the credential is unverifiable, and sometimes people also send in fraudulent credentials. I'm not going to tell you how to do that, but we all know that you could buy all kinds of stuff on the internet, including diplomas, and it will get you in trouble. And if you try to apply for a work permit using fraudulent credential or getting your professional license, then not only will it be refused, but we will probably never be able to work in Norway at any point. You will have like permanent ban upon you. So stay away from that. And they also have like an official checklist that you can double check before submitting. Because even if you get refused, then you need to resubmit and it will take much longer time. So let's talk about some strategies for learning Norwegian. Perhaps I'm not the best to listen to on this because I'm a native Norwegian speaker, so I didn't really have to learn Norwegian consciously. I was just taught when I was a little kid. But I'll share some insights that I've gathered from colleagues and some official recommendations in terms of learning Norwegian. I will also share some of my experience working with international healthcare professionals who are having Norwegian as a second or third or even fourth language. Okay, so there are many tools to learn Norwegian, and usually you have to start where you're living and then intensify the learning when you move to Norway. It's really hard to learn a foreign language without being in the country itself. So, but you can start, you can learn the basics, but if you have someone to talk to, like an online friend or someone in Norway, it will make the process much easier. Maybe you could get like a conversational partner, and in at least in Europe, it's fairly easy to find Norwegian students, and maybe they want to be your language buddy for a few hours a week and get some in exchange for a small salary. So there are a lot of options there, but there are loads of digital courses. The Learn Now is one that is frequently recommended. It's from one of the Norwegian universities, NTNU in Trondheim, which offers a comprehensive language package for at least complete beginners in Norwegian. But there are obviously some paid services as well, and they're just a Google search away. You'll find loads of different online programs teaching Norwegian, and you'll also find some YouTube videos, etc. But my recommendation is that if you get someone to talk to, it will be that much easier. So, communicating in Norway, it's not just language. It could be also that we have some cultural differences, and it's kind of hard to paint a broad picture of the Norwegian culture because there are vast differences between different regions in Norway and between different families and so on. But I'll talk about some general stuff that may be different from where you're living at the moment. So we generally are quite informal. We rarely use last names, both when talking to patients and colleagues. So we're usually addressing the patients with their first name and also our colleagues. Some older citizens may prefer to have their last names used, and maybe also some more senior colleagues, but generally speaking, it's fine with the first name. And what I sometimes do is I just ask the patient what they want to be called, especially if they have like double names, which are quite common in Norway. Like they have two first names, and sometimes they're only using one of them. And if I'm like saying hi to them the first time, they may not really say their name. I'm just going into the waiting room and asking for um, Geir Trygve, and maybe he just stands up and says yes and shakes my hand, and then I can ask him what he wants to be called. Oh, he's just called Geir, you know? So, and you can also do that for last names. But generally speaking, first name is fine. Um, yeah, so as a healthcare professional, we expect you to be clear and be calm and just use plain Norwegian. So the thing here is that patients don't want you to use like advanced medical jargon. And in English, for example, the medical jargon and the jargon used by, or the language used by everyday people are not that different. Usually, for example, they many people in the general community, they use words like the femur, for example. But in Norway, we use more like lårben, and only in the medical communities we know about the term femur. So if you're unsure, and this is, I would also say, if you're communicating with colleagues, just to avoid any confusion, as depending a little bit on your profession, then it's always better to just use the plain Norwegian word if you know that. But one disadvantage is that you may not know the plain Norwegian term, but you know the Latin term, for example, and try to learn the Norwegian terms for that, because the patients will not understand those terms, and sometimes even not your colleagues, depending on your profession. And we also really encourage shared decision making, both as a cultural phenomenon, but also as a legal one. So the patients have the right to say their opinion, and they should also be asked for their opinion. So it's not like the doctor or the nurse says that the patient needs to do so and so, but we always try to ask what the patient thinks themselves about the different treatment options, so to say. That is not to say that you shouldn't give a recommendation, but try to get the patient's perspective as well. So in the Norwegian culture, generally, silence is okay, and when learning medical communication, we're often encouraged to kind of sit through the sometimes uncomfortable silence when talking to a patient, because more often than not, they're actually thinking, or just giving them a little pause can get them to really tell you something really profound that they're worried about, or something like that. So silence is generally not that awkward like in a medical setting, and just usually let there be silence if it's appropriate, and wait for the patient to say something. So if you're like delivering them bad news, for example, just deliver the news, be silent, and then just wait for the response. Don't try to fill the gap. So we try to avoid the medical jargon when speaking to patients, and try to explain it in as simple terms and words as possible. And as healthcare providers, I think that's not just like a problem in Norway. I think that's everywhere that we sometimes, for me, being married to another doctor, I kind of forget what is the usual term for things because you get so ingrained in like the medical nomenclature of things. So you must really try to be conscious about that. So I'm not going to go through all of that. This will be in the compendium with links and everything, some recommendations for places to learn Norwegian, both free services and some paid services, both from universities and also some private stuff. I would like to just to toot my own horn in Akuttundervisning, we have a YouTube channel with loads of videos in medical procedures that you may know as a healthcare professional, but just seeing them explained in Norwegian with all the Norwegian terms could be useful. And some of the videos also go through some relevant Norwegian procedures that we have. So I would, if you're not subscribed to Akuttundervisning on YouTube, I would encourage you to do that. And we also have an English counterpart called Learn Emergency Medicine, where we don't have as many videos yet, but we're working on it. And both on Akuttundervisning and the English counterpart, we have some videos where we explore the different part of the Norwegian healthcare system. I will send you a playlist of all the relevant videos. We have some in English on the English channel and some in Norwegian. So we have made interview with a doctor up there in the far north where I was working before, as well as a paramedic there about some of the unique challenges. We have been to emergency vehicle operated by the Legevakt. So you could, by watching those videos, both get insights into the Norwegian healthcare system and also learn some Norwegian along the way. And our national broadcaster, NRK, Norsk Rikskringkasting, they also have some amazing free documentaries. Usually you need to be on a Norwegian IP address, which means that you either are in Norway or you are, I'm not sure if I'm supposed to say that you could use a VPN, but yeah, you need to be on a Norwegian IP address to watch. They have a lot of documentaries in Norwegian. If you that's also a way to learn as well. Okay, and they have some medical shows as well. So some final tips for succeeding with the Norwegian language. Start learning before you move. It's more easy to start talking to people. And try to be consistent. Even as little as 15 minutes a day will be much, much better than nothing at all. And 15 minutes a day for several weeks and months will really add up. If you're trying to go the intensive route and just read and practice for 8 hours a day for a few days, it won't even get near to the proficiency we'll get from being consistent just a little bit a day. So the thing you need to focus on is both like the general Norwegian language and everyday words, but you also need to look into some of the specific medical words that you will be using and some phrases to ask patients about allergies and also, yeah, some common stuff from your particular profession. So when you move here and you start working, use your job to learn. Treat every patient interaction as a lesson. See if you can learn something from it. And I would like to show you a cool thing. So there are different AI services, but they have gotten amazingly good over the past year. So do not use this with patients. And now I'm going to demonstrate something from ChatGPT, but it's when you're doing this with a patient, then you're basically giving ChatGPT confident patient information, which you are not allowed to. And the information shared with ChatGPT will be stored somewhere and will be accessible by someone, so that is not okay. But it's a great tool to learn. So this is ChatGPT. You need to be on some kind of paid plan, I think, but there are loads of different alternatives. So, hey Luna, I call her Luna. I'm holding a course now about the Norwegian healthcare services, and we're talking about learning Norwegian. So I would like you to pretend to be a Norwegian tutor, tutoring me, um, basically teaching me to learn Norwegian from scratch. And I want you to do that in English.
Got it. Let's dive right in. So, one of the first things we can do is learn some essential phrases and words that you might use in a healthcare setting. For example, if you want to say nurse in Norwegian, you'd say sykepleier. And if you want to say doctor, you'd say lege. We can start with these words and build up your vocabulary from there. Sound good?
Yeah, sounds good. What do I need to do now then?
Let's practice those words a bit. Try saying sykepleier for nurse and lege for doctor. Once you're comfortable with those, we can move on to some simple phrases or maybe even practice a short dialogue. Just let me know when you're ready.
Okay. Sykepleier.
That was great. You're doing really well with the pronunciation. Now let's try lege for doctor. Once you've got
Okay,
that down,
let's cut it there. Just give me an example of if I'm more like an intermediate or advanced learner, how our conversation could look then.
sure, if you were at a more intermediate or advanced level, we could have a more in-depth conversation entirely in Norwegian. For example, we might discuss your experiences working in the healthcare field, or we could talk about different aspects of the Norwegian healthcare system. We could dive into more
And
complex.
I'm sorry, and basically then you'll, I guess by that point you'll be talking Norwegian. So try tutoring me a little bit in Norwegian now.
Selvfølgelig, vi kan prøve det. Så hvordan har dagen din vært så langt? Er det noe spesielt du har lyst til å snakke om, eller noe du har lyst til å lære mer om på norsk? Vi kan ta det i ditt tempo.
Dagen min har vært veldig bra. Jeg har vært på jobb på sykehuset og behandlet mange pasienter.
Så bra å høre at dagen din har vært fin.
Yeah.
Det høres
You get the point. And as I've talked about, for me, when I'm practicing other languages, having someone to talk to is great, but AI is like the second best. And what's cool about it is that it doesn't judge you and it's available 24/7. And if you're like not comfortable enough to speak with other people in Norwegian yet, or you can't like really find a language buddy, maybe in your home country to practice, then it's at least better than just listening and reading from a book. You get to practice the language a bit. And ChatGPT and other services, they are as far as you can pronounce the words in an understandable manner. They are not so good at coaching you in terms of accents and those kinds of stuff because they're basically transcribing what you're saying. And then they don't really get accents or those kinds of nuances. However, the important thing is to get yourself understood. And if ChatGPT can understand you, then hopefully the patients can as well. So yeah, I'm using that really to brush up on both my English and my German and so on. Yeah, that's just one tip. And I personally, I have much more respect for people who are open about being a Norwegian learner, and especially when they say it to the patient, then and encouraging the patient to let them know if they say something strange or if the patient doesn't understand them. Perhaps depending a little bit on the setting. So celebrate your small wins. Norwegian is a hard language. So the first time you're able to write a full note or hold a consultation or explain medication clearly in Norwegian, then celebrate that. So some other tips on communication while you're still learning English is just keep it simple. Use short, clear sentences. It's much more important to be understood than to be clever and have everything grammatically correct. And if you use short sentences, it's easier to understand you, even if there are some grammatical errors and so on. Oh, ChatGPT wanted to talk more. Not now. Yeah. And ask one question at a time. If your Norwegian is not there yet, at the level you want it to be, and you're already started working with patients, or if you're practicing with other Norwegian speakers, I would recommend to just do one question at a time and keep the sentences short. Avoid combining multiple questions, as it will get more complicated both for you and for the people you're talking to. And you can get a long way by using gestures and drawings. Like you can draw with a piece of paper, or you can, for example, if you have an anatomy book, you can point and so on. And obviously you want to be at a better Norwegian level than this when you're working with real patients. But sometimes, even if you're having the B2 level Norwegian and you can talk like fluently with a lot of patients, you meet a patient with a strange dialect. They may be cognitively impaired, they have weak hearing, and then it could make your language skills, which are usually more than sufficient, not sufficient enough for that patient. And then you could supplement. And I need to do that as well as a Norwegian patient when I have a patient that has hard hearing or have some kind of mental challenge in regard to understanding and so on, then using like body language, nodding, shaking your head, and so on. Just make sure that generally those kinds of nonverbal language cues are the same in Europe and much of the Western world. But if you're from a not completely different culture, then some of those nonverbal cues may mean different things to you compared to Norwegian people. So just make sure that it means the same, which is generally not an issue for you listening today, I guess. And this is something that actually is encouraged not just for Norwegian learners, but for all kinds of medical professional, is to use the teach back method. Basically, ask the patients to repeat back what they understood. And I think we should be using this much more. When we look at prescriptions, for example, and advice given to patients, when I'm asking some of my family members who have been to the doctor's office and asking them what really happened there, what are they supposed to do, they are usually quite clueless. Patients understand much less than you think. And I don't know if it's a Norwegian cultural thing or if it's more universal, but it's very typical that patients want to be positive and they nod and smile and say, yes, yes, I understand. And they don't understand anything, or they think they understand for a brief moment and then they forget. So if it's important, if the patient need to be fasted before surgery, if the patient needs to hold off on the blood thinners for a few days because they have hit their head, then ask them, just to be sure, use a closed loop kind of communication. Ask them, I just want to be sure, because this is so important, that you have understood what you need to do with your blood thinning medication now. I know it's not called blood thinners, they're anticoagulants now. Could you please repeat for me what you need to do with your medication the next 2 days. This can be a really important thing in terms of patient safety, and it doesn't matter if you're having Norwegian as a first language. This is just as important, especially in the cognitively impaired and people who have some kind of communication difficulty in terms of hearing or sight or anything like that. And I encourage you to be transparent regarding your Norwegian levels. And obviously, you should have a language level um, where there are no confusions when you're talking to real patients. But if you're not there yet and you're put in a position that you maybe should not be in, then at least try to understand when you need an interpreter or need to hand that particular task over to a colleague, especially if it's in regard to patient consent, diagnoses, complex treatment plans. Make sure to qualify. I'm sorry, to either use an interpreter or a colleague, usually a colleague. Here are some key clinical phrases. I'm not going to go through them now, but there will be these ones and loads more in the compendium that you could like to sharpen up on your Norwegian, your medical Norwegian. And when you're communicating with colleagues, I would encourage you to encourage them to help you practice Norwegian. So if your Norwegian is not there yet and your colleagues switch over to, say, English, because most Norwegians are fairly proficient in English, then politely ask them to speak Norwegian. It may be more comfortable for you to speak English with them in the break room, and then you must speak Norwegian when you're talking to the patient, but you'll learn much more slowly. So please. And it also, if you have someone from say your home country, also working the same place, it's super easy to switch over to that. And I can really relate to that when I had, even if Danish and Norwegian is not that different, then if there was another Norwegian doctor in Denmark, then we will usually talk Norwegian in the break room and so on. And it's maybe a bit unpolite for the other colleagues there, and I'm not learning as much Danish as I should be doing. And one of my pet peeves is that you never pretend to understand. We're working with real living humans, and we all have the tendency that if we don't understand something, we may ask for a repetition. But if we still don't understand, we don't want to seem stupid. So we just say, okay, don't do that when we're talking about patients. If you need to ask for a repetition a third time, ask for your colleague to repeat it more slowly, to rephrase whatever it needs to be, because it may be an important message, and you must always make sure that you understand. And if you need to have them say it in English, it's 100 times better than just pretending to understand something you don't. And also using the closed loop communication. I have a YouTube video where I talk more about that in like when we communicate in emergency medical teams, where that is a common practice. But I encourage you to use that also in day-to-day work. So if your colleague asks you to go get like a suction catheter, for example, you say that, yeah, I'll go get the suction catheter. That way your colleague knows that you have understood without asking you, basically. So there is a lot of site-specific lingo in Norwegian hospitals and different healthcare sites. And the intensive care units are some of the worst. They may have different abbreviations for the different kinds of intensive care units or the different kinds of procedures. They may vary between hospitals and services. So there will be hospital-specific abbreviations and phrases that you need to know about. So make a small notebook of that. And that doesn't go just for Norwegian learners, I do that myself when I'm working in a new place. One thing that I'm doing, because I'm horrible with names, is that when I'm introduced to different colleagues, at least when start working there, I try to write down their names, or I find a list from my employer, and I'm not stalking them on social media, but I try to find some pictures of them and confirm if the right one. And I'm basically making myself a notebook to help me learn. Okay, so that's her. That's her name. She is the chief doctor on the unit, and have those kind of specialities, and maybe also who I can talk to about different kind of stuff. So yeah, no, that's the way my brain works anyway. Yeah, so there may be a unique workplace culture that you need to familiarize yourself with. And don't be afraid to ask for feedback from a colleague. More often than not, they're more than willing to help you excel in Norwegian. So, some final advice on language before we move on to the final topics. So, generally, apart from when we're talking about important patient stuff, more as a learner in the break room or out in the society, don't fear mistakes. Language learners are generally respected around the world when they try. You're much more respected when you try and make a mistake than if you don't try at all. But of course, when dealing with patient safety, such as medication doses, procedure, or critical documentation, mistakes are not acceptable. So make sure to double check anything and ask for help if you're at all unsure. So, I'll just catch a breath and take a small sip, and we'll talk about some other things that can help you in your Norwegian healthcare journey. So first, we need to talk about antibiotics. In Norway, fortunately, we have quite a different bacterial resistant pattern than even the rest of Europe and Scandinavia, at least the rest of Europe. And we would like to keep it that way. Fortunately, in Norway, normal penicillin actually works for quite a large portion of pneumonias, throat infections, and so on, whereas that is not the case in other parts of Europe and especially other parts of the world. So if you're used to working in healthcare services in another country, or even if you're educated in another country, then you need to familiarize yourself with the Norwegian national guidelines for antibiotics, which are tailored to our unique resistance patterns. So we basically have two of them, and at least for me, who is not like a genius in microbiology, I just follow these from point A to point B. And I generally don't make that do anything else than that is written here. And they include all the caveats. If the patient have kidney failure or allergies, or if it's like in a nursing home, they have recommendations for all those kind of special circumstances as well. So you don't really need to be clever, and you shouldn't be, unless you're an infectious disease specialist. Then you may do some additional evaluations, but it should still be like based on the resistance patterns in Norway, obviously, and you need to familiarize yourself with them. So we have two guidelines. We have one for the primary health services, that is for GPs, legevakt, nursing homes, home nursing, and so on. And we have one for the specialist healthcare service, basically the hospitals. And they are much the same. They are from the Helsedirektoratet, the Norwegian Directorate of Health. And there are a lot of similarities between them, but generally, here you find advice for IV antibiotics, and here for per orally administered antibiotics. So we'll link to that in the compendium, and just use that and look it up and familiarize yourself with it. And even if you're not a doctor, you'll still play a part in like doing quality control and so on. So if you're a nurse and the doctor prescribes like a really broad spectrum antibiotic for a simple infection, and you know that is against the guidelines, then try to be street smart and in how you communicate it, but try to lead the doctor down the right path. Maybe there is a reason for the patient getting the more broad spectrum antibiotics, but maybe you should at least ask the question why the doctor wants to prescribe such an antibiotic. Because some patients obviously need other thing than the standard. Maybe they have some unique resistant patterns or diseases. So, expect and you are expected to follow the strict national guidelines that we have. And you're not expected to prescribe broad spectrum agents unless there's a clear indication like sepsis or specialist approval. And we use a lot of what we call watchful waiting. So in some infections, even if we suspect that there may be a bacterial cause, then sometimes we do the watchful waiting. Maybe for ear infection, that can be both bacterial and viral in origin. Sometimes it gets better on their own without antibiotics, and sometimes we give the patient a prescription, a wait and see prescription, or a vent og se recept, and actually tell the patient, and we don't want you to use this unless the symptoms get much worse or doesn't get better in, say, a day or two. So that's also something that we frequently use to avoid using antibiotics when it's not necessarily. Obviously, it depends on the infection. So it's not something that is suitable for all kinds of problems. Yeah, so there may be different patients' expectations, and you need to educate the patients about why antibiotics is not needed. And generally, we, of course, we don't give antibiotics to viral illnesses. And all of this need to be documented thoroughly. So we use narrow spectrum antibiotics first, if it's not like a life-threatening illness or something special going on. So we use a lot of normal penicillin, and we also use a lot of pivmesilinam for urinary tract infections. So just familiarize yourself with the guidelines. Some other protocols that you should familiarize yourself with, and that we will link to in the compendium, that are unique are our resuscitation protocols, especially if you're working with ACLS, that is advanced cardiopulmonary resuscitation, or AHLR in Norwegian, like giving adrenaline or epinephrine in cardiac arrest, and using more kind of advanced treatment plans for cardiac arrest, then our guidelines in Norway are completely different from the rest of the world. We go around here in 3-minute intervals and not 2. And we also have a kind of unique system with both circulation checks and rhythm analysis. So if you're expected to do something like that in your line of work, that could be in legevakt or the ambulance service, and obviously the hospitals, at least for some kind of healthcare professionals, then I really recommend you to take a proper course. I'm licensed as an instructor, so if you need that course, then please let me know. So, and we also have a lot of guidelines from the Norwegian Directorate of Health, the Helsedirektoratet, and some I would like to highlight is the guidelines for palliative care. We have a lot of different guidelines for different kind of circumstances, and they have also inspired our course on palliative care at the end of life. So we offer a basic course on that following the Norwegian guidelines. That course is in Norwegian, as all our other courses. This is the first one we're doing in English, but if the demand is there, then we may do some of the other courses in English as well. There are specific guidelines for psychiatry and also for different cancers. For cancer, we have these kind of pakkeforløp, which means that if there is a high suspicion of cancer, the patient is not just sent to the hospital and asked for an evaluation. They go into like a predetermined pathway, which says that within so and so many days they need to do like depending on the type of cancer they're suspecting, like a CT scan, a biopsy, an endoscopy, whatever. Within those kind of days, they need to get the results in so many days, and they need to like basically be diagnosed and sent to a treatment plan within a predetermined amount of days. So if you're working in primary care, for example, or if you're seeing cancer patients in the specialist health service, you need to obviously you need to get to know those pakkeforløp. Yeah, we'll look into the advanced cardiac life support another time, but there are vast differences here that you need to learn. But yeah, the general principles are the same. It's just that the flow and the rhythm here is following a different time kind of scale, so it could be a bit confusing. Some legal essential, wrapping up with that, we'll link everything in the compendium. You need to get to know the patient rights and the laws surrounding that, the pasient- og brukerrettighetsloven. Some key points from that is that the patient actually has a right to necessary care. They do not have a right to unnecessary care, but they have rights for the care that is necessary and appropriate. They have free choice and they have the right for second opinions. So if I want to operate my knee for arthrosis, say, I could actually choose that I don't want to go to my local hospital. I want to go to a hospital in the west of Norway because I've heard great things about them. And then I can actually choose that as I want to. This is not applicable for emergency admissions. So if you're admitted for pneumonia and the patient doesn't like their hospitals, unfortunately, that is not so uncommon, then the patient can't really say that, no, I want to be transported to another hospital. And usually the other hospital is far away and it will be basically put that ambulance out of service for a prolonged time. So generally, we don't do that. We send the patient to the appropriate hospital in emergency settings. I see that I'm running a bit over time, but there will be a recording, so feel free to, if you need to go do something else, and you can watch the final minutes later, but I'll wrap it up in 5 minutes. So the patient actually has a right to information about their treatment and be a part in deciding the treatment plan. Obviously, the patient can't demand something that is not medically sound, but they have at least a right to be part of the discussion, at least when there are different equal treatment options. So we practice informed consent, and the patient has the right to refuse, but it's not so strictly practiced as in other countries. So generally, the patient doesn't need to sign anything to prove consent. We're usually doing it when we talk to them, and in some cases, especially in like emergent cases, it's usually enough that if the patient doesn't refuse, then they're kind of they're assessed to be consenting. So if you tell the patient that I'm going to put in a small cannula in your bloodstream now, and if they doesn't really say anything against that, then basically that is treated as the patient consenting. However, it may be more strict if there is a procedure with a higher rate of complication, and you maybe need to disclose those kind of risks with the patient, and it may even be necessary the patient actually signing some kind of form. But in day-to-day life for small procedures, and especially in emergency medicine, we usually, if the patient doesn't say that they don't want something, then it's usually okay. One important thing to note is that the patients have access to their medical records. Not every kind of notes, but they have access to quite a fair bit. Sometimes they can just log onto their computer and access those medical records. And at least they have the right to go to, for example, their general practitioner and say, I want to get all my patient records. I want them printed out and handed to me, please. And that's the patient's right. So you need to think about that when you're writing the patient records, that it's written in a way that should, of course, be correct, but that stands to see the light of day, and be mindful that the patient might read it. And so I'm not going to say that you should write something that is untrue just to please the patient, but just be mindful of how you characterize the patient. So what I like to do is, let's say that the patient is morbidly obese. That is, strictly speaking, a medical term, but it can be a bit offensive. So what I like to do is just like writing some undeniable objective things. So if I, for example, just write the patient's height, weight, and BMI, obviously they can have a lot of muscles and so on. Maybe I also write down their waist circumference if I've measured that. And I also maybe write down some objective things about their level of movement or their dietary patterns, something that they have told me, and I put in quotation. The patient says that their diet consists of so and so. And so instead of like putting a label on them, I'm just basically putting down objective information that I've either measured myself or that a patient have told me, and I've put them in quotation marks. So that's one way to do it. And it's actually, for me, as when working in anesthesia, it's much more useful to actually get the different kind of data than just somebody writing that the patient is morbidly obese, because that could mean all sorts of things, even if it has a definition in terms of BMI. So we have a duty of confidentiality. So there's some more details there and in the compendium, but basically the things you're taught as a healthcare professional are not to be shared with anyone else except for those who need to know to care for the patient. And this also applies when you're a healthcare professional in your spare time. So it doesn't mean that you have confidentiality in terms of everything you ever are told, but say that if a friend approaches you at a party because they know that you're a healthcare professional and they really need your help, they have some kind of personal problem, then they are actually coming to you because you're a healthcare professional, and then you're bounded also by the confidentiality, and you could get into trouble if you share that with anyone else. So that's also something to be mindful of. There are a lot of exceptions that you should familiarize yourself with. Obviously, you're not only allowed to report suspected child abuse, but you're also you have to do that. So that is not just something you're allowed to, that's something that you must do. Either through the child welfare services, or not, or and if necessary also the police. What we do, just to take the practical aspects of that, if you have a child that is in immediate danger now, they are full of bruises, you expect that it may be like the primary caregivers, the parents who are behind it. It's not enough to report it to the child welfare services. That will be like a bureaucratic process that takes time. So you can call the police and get them to like intervene, but what you really should do then and there is just like admit the patient to the hospital so they can take care of the child there, and the child department will make all the other things happen. But you have an independent duty to report to the child welfare services as well. So you must do that in addition, but admit the patient to the hospital, and if you're not a doctor, then get the doctor to do that basically. And make sure that the child doesn't travel to the hospital just with the potential abusers. Send them with an ambulance, for example, or involve the police if necessary. So we have a duty to provide emergency care for patient, which is sharpened compared to like civilians, which means that if you're authorized as a healthcare professional and you're just driving past a car crash, obviously you could get in trouble for that as a layperson as well, especially car accidents, which are regulated in a specific law. However, it's even more important for you as a healthcare professional to act if somebody is acutely unwell on the street or somewhere else. So you have an obligation to help, and there are also not the same need for consent for the patient if they're unconscious, obviously. So yeah. There's also some laws in psychiatry that you need to familiarize yourself with if you're working in that realm, or if you're working in primary care and taking care of those patients, especially for doctors. And make sure that you understand when involuntary psychiatric care is permitted. The patient needs to have a serious mental illness. There needs to be danger to the patient itself or others, or the patient need to risk major health consequences if they're not forced to be admitted to the hospitals. Obviously, there's more to this, but make sure to familiarize yourself with that. Okay, so this is the second last page of this presentation. I will make a large list in the compendium with some digital tools to make your life easier. Some of them are depicted here. Others will be added to the list, but we have for medications, we have the fastlegeordningen, which are made by the drug companies. So they are generally long texts with all kinds of legal writings and disclosing all kind of potential side effects. So it's not so easy to navigate to, and it's also really conservative in terms of medication to pregnant patients, for example. Basically, you will always read in the fastlegeordningen that the medication is not tested in pregnancy, and basically then you're left with no options for your pregnant patients. For those kind of situation, I usually rely on RELIS, which is a pharmacological information service, which are founded by the government and not by the medical industry. And there's also a site called Trygg Mamma Medicine, or Safe Medicine for Mothers, which I use a lot, which I will also link to. And there are different kinds of resources. Also, the Legevakthåndboken is one of my favorites, both when I'm working legevakt, but also perfect for paramedics and EMTs who want to look closer into some kind of issue in addition to their local protocols. So that was all for this introduction. The recording will be sent out to you, and if you want to learn more, we have a broad spectrum of different courses available. As I said, they're all in Norwegian except for this one, but who knows, maybe we'll offer someone some in English in the future. And either way, it's a good way to brush up on your Norwegian and kind of hone in on those Norwegian medical specific words. So the opportunity is coming up. Tomorrow we'll actually do this same course in Norwegian, and you're free to tune in then as well. There is some information in the emails you have received previously about that. But if you haven't received that, just shoot us an email at post@akutundervisning.no. And we'll help you out. And other than that, the upcoming courses is our course in blood samples, which goes into how to draw blood samples through an introductory video. But the main focus is actually interpreting different blood values. So if you're an experienced general practitioner, it will probably be too basic for you, but it's perfect for like nurses and other kind of healthcare professionals who want to understand more about all the different lab results they see, for example, working in the ER. Or if you're an experienced GP, maybe you just want to brush up on your Norwegian, it could be an opportunity for that as well. And we have the 24th of June, we have our course in palliative care at the end of life, which basically goes through identifying patients who are dying and going through our recommended treatments and procedures based on the Norwegian guidelines. So it's a basic course, perfect for people working in nursing homes or in home care nursing and those kinds of arenas. So yeah, that's all for today. Thank you so much for tuning in, and I'll hope to see you another time. If there's any more questions, then please write to me, and if not, then you can write the questions in the recording. There will be a comment section down below there as well, or send us an email. And yeah, basically, hope you have a good day or night, actually. Bye bye.